afternoon. So my title is Rise to the Challenge. One might notice right away that it says in red, one to all. I plan on being the change. So today's agenda, we'll go over introduction, background, problem statement. I'll show the objective of review, methods, some definitions, the utilization of mental health services, barrier treatment options, treatment therapies, the effectiveness of treatment therapies, what the Veterans Affairs Department of Defense, which is VA/DoD, what they have implemented, and what expert analysis says, and some recommendations for you. So, since the war on terror has begun, 2.2 million troops have deployed. Of these, 6,600 are dead, 48,000 are wounded. Those that are not dead or wounded are left with invisible scars that are on their minds and soul. 500,000 of these veterans are left homeless. 25% of these veterans make the whole total of those that are living homeless today. 58% of these veterans have been diagnosed with PTSD, and 56 to 87% of them have not received help. I want you to view the picture. It's really small, but it says facts. 22 veterans and 1 active duty soldier are lost per a day to suicide. Their pain outweighs their coping mechanisms, and I want you to realize as you sit here today through these presentations, 4 veterans have already committed suicide by the time we finish here today with the Undergrad Research Conference, and the 5th one will be ready to commit. My problem statement. In veterans with post-traumatic stress disorder, what is the effect of the current Veterans Affairs PTSD program on engaging and retaining these veterans once they're diagnosed? Like I previously stated, this just comes straight from my paper. It's for your own reference. My methods, I did a comprehensive literature review using CINO, and some keywords I used was soldier, veteran, service member, OEF, OIF, which is Operation Enduring Freedom and Operation Iraqi Freedom, post-traumatic stress disorder, shell shock, Veterans Affairs, DoD, group therapy, PTSD therapy, and treatment barriers. I obtained altogether 8 journals, and I reviewed them for my review. Definitions, I'm just going to hit the signs and symptoms. When it comes to PTSD, a lot of veterans and people suffer a trauma. So that is the first thing. You have to experience a trauma. The next thing is you have to re-experience these traumas through nightmares, recurring thoughts, and flashbacks. Then what will happen is you'll have avoidance. People will avoid. They don't want to talk about it. The next thing is you'll have emotional detachment and hyperarousal. Sometimes you'll have a startle reflex or, like I said, problems with sleep. And a lot of it is anger. And when they can't deal with this, they have relationship issues. This is just the VA/DoD's definition, how they get diagnosed. Now to coping mechanisms. It is extremely important to understand how this population of veterans, deals with their trauma. For males, they will use alcohol and substance abuse. They will display actions of aggression, landing them behind bars. They have extreme difficulty with their relationships. They don't know how to communicate with their civilian spouse. And to actually get them to understand, I went through this trauma, I had to do something overseas. They'll recklessly drink, they don't care, they're trying to cope, they're trying to forget about what they saw, and a lot of them commit the lethal suicides. For the females, they will self-inflict harm. It's their kind of way to cope. They want to express themselves, they want to talk about it, but they don't know how. They have increased anxiety, they'll avoid their triggers. A lot of their triggers, I didn't cover it in my paper, but a lot of it is sexual assault that happens overseas. So they will avoid males. They don't like being around them. And if they are, they'll get out of Dodge as fast as they can. A lot of their relationships, because of the sexual assault and stuff, if I did put more in my paper, a lot of their relationships end in divorce because they just can't be around a male person and they can't talk about their trauma. They will binge drink and they will attempt suicide, but they're not as lethal. Now we move into the utilization. Less than 1/3 complete adequate treatment once they do get diagnosed. Over 25% of them do not return after their initial treatment. More trauma, like the greater trauma and greater deployments that the veterans have, the less likely they are to complete treatment. They also found that with a PTSD residential program, veterans actually completed more programs over time with those programs, so we need to institute those. Two variables that lowered likelihood of actually seeking treatment, which I found shocking and needs more study, is being married and mild brain injury. And longer delays equals fewer treatments. We need to have a fast turnaround. If you're going to diagnose a vet as a healthcare professional, you need to make sure that they have a fast turnaround to get those treatment options. Next, we have the perceived barriers of treatment. Within the military, there is a stigma. Over 25% of service members reported they were discouraged to seek treatment. This comes from their commanders and their leadership. We need to try to change this atmosphere, and I plan to do that. I was told by a lieutenant colonel just a couple weeks ago, he said, if you want to be the change, you get in with my unit, you be there, you be the change. So when Joe Snuffy comes up to you and is talking to you, the first thing that doesn't go off in my head is, Joe Snuffy has a problem. No, he's talking with Lieutenant Guerrier. He's just talking. They're just talking about whatever, and it's not going to cause a stigma. Their perceived barriers is, I'm uncomfortable in crowds. I'm not comfortable showing my emotions. There's faker present. I'm not going to talk about my trauma because Joe Snuffy over here, he's just faking it. They'll lose their mind if they talk about it. And difficulty making appointments and juggling their life. And the one thing I found amazing with the barrier treatment is less than 0.9% stated, I would think less of a veteran if I knew he or she was receiving mental health counseling. So if they believe that, if our veterans and my fellow brother and sisters in arms believe that, then why is there a stigma in our ranks? Next is treatment therapies. I only covered, in my paper there's 11, I'm only covering I think 4 today. So the most common is cognitive behavioral therapy. It focuses on education, common reactions, relaxation techniques, and modifications of thought. Then you have integrative cognitive behavioral therapy. It's CBT, except they integrate it to include military terms and traumas that military professionals and veterans and everything can actually understand. It's manual guided, individual group format. It focuses, again, on patient education, mindful relaxation, and flexible thinking. Then you have transcend therapy. This is for veterans that have PTSD and use substances to cope. With this, it's a 12-week intensive program. It focuses on decreasing the symptoms and living an addict-free lifestyle because you have to get off the drugs in order to actually understand what your body's going through and actually cope. So like it is 2 phases. You write a narrative, you make the story real, you make the trauma real, it's gonna hurt, and we're gonna be there along the way to help you. You're gonna self-accept, you had nothing to do with this is something that you did, you were a part of, you didn't do it. Then you do relapse prevention to prevent the substance abuse, and then you also gain peer support. After this first phase, you then go through weekly group sessions within the group, and you do this for 6 months. Then you have cognitive process therapy. It's 60-minute sessions, consist of 4 stages. Then you have prolonged exposure therapy, which is 10 to 12 90-minute sessions. They basically are reworking our thoughts. This is a bad thought. This is how I change it to be a good thought. This is the effectiveness of treatment. With CBT, once begun, if you do it 1 month after the trauma begins, then the long-term benefits is so much better. 91% of veterans that did at least 1 session of integrative cognitive behavioral therapy actually liked it. The tolerability was 54%. Transcendence, there's a significant reduction. More research needs to be done on the substance use. And then CPT-PE, there's a 61% adherence. For group therapy, health professionals need to understand the client. PTSD symptoms need to be normalized and acknowledge the needs of the client. For the VA, in 2004, they had a post-deployment screening, and they created a handbook that had 4 aims to actually understand what the plan was for PTSD. Expert analysis, they require, you need an honorable discharge to actually get into the VA system. The wait list is far too long, and we need to get rid of the social barrier. Several recommendations are in here. You can review them yourself. I'm going to jump to 9 real quick before I end. For 9, we need to increase the engagement of PTSD program alongside the VA-DOD. We must decrease the stonewalling of care. We need to have therapeutic communication. We need to have treatment approaches that begin with everybody, the patient, their family, and the healthcare providers. We need to be educating them on all their treatment options to make the best choice. We also need to establish integrative therapies for all their disorders and comorbidities. And lastly, we must meet them where they are. So with this, are there any questions?
Is there any statistics or information about which of these therapies might actually be working?
As of right now, the cognitive processing therapy and PE are the better options. Group therapy is coming right up along. So right now there still needs to be more research on which are most effective, because if I went into more detail, a lot of veterans, they like the individual because they don't like to talk in group settings. But in relation to civilian sector, group therapies come a long way. A lot of people have been able to cope through that. So I would push towards group therapy, but you have to know your client. Will they actually be able to do group therapy and actually sit through and talk about their trauma? Anything else? So I leave you with this. Meet them where they are. Thank you.